very much, Jackie, and it's a real pleasure to be here with you all this morning. And I'm really excited to be back in Canada, it's true, but I'm also very excited to meet up with my colleagues and emeritus colleagues, my alumni colleagues rather, from Mayo. It's great to see Sharon, my other Sharon. As a matter of fact, they tried to make me into Sharon, but I used to joke because nobody ever spelled her name right because it had the extra N-E on the end of it. But now I check in and my name has the extra N-E on it. We're all good. So I have a very short period of time to go over a very huge and important topic. But I think what Jackie wanted me to do, if I got this right, is just to kind of set the landscape and the overview for where we're going with this. And which one do you want me to use as far as the mouse or the stance?
Get the down button.
Sorry, the down one here? Sorry. Oh, this one here? Okay, the laptop. Just okay. All right, good. All right. Okay, very good. And I don't have any versions relevant to this talk today. So, heart disease, of course, is the leading cause of premature mortality in Canadian women. And the important thing is that many women and their healthcare providers are not aware of that. And that was documented in a recent study by the group of the Hearts Institute. But indeed, if you go on StatsCan, you'll see that at least a third of deaths are in women that are cardiovascular. Cardiovascular deaths account for a third of deaths in women, which is actually slightly more than, it's like 31% versus 30% in men. So it's a more than equal opportunity killer. And what we all think women die of is breast cancer, right, as women? But indeed, heart disease kills 5 times more Canadian women than breast cancer does. And women are Canadian women have at least one cardiovascular risk factor, and many of us have more. And we're also more likely to die after a heart attack. So what I'm supposed to talk about is what is the epidemiology and what are the causes. Because it's not just the same in women as it is in men, and that's been part of the problem. And this is, believe it or not, only become to the surface of awareness over the last decade, or decade and a half at most. So the top 3 cardiovascular-related causes of death for Canadian women are ischemic heart disease, and stroke and heart failure. And this is a bit small, but I wanted to share with you that when we talk about ischemic heart disease, which one can I use for the mouse here? Is it this one up here? Does that show? Okay. So we have a big lump here, and you can see it says 32,000. This is the most recent data from StatsCan and CIHI combined. Canadian Institute for Health Information. And we just put together this data. We submitted it to data circulation for the Go Red issue in next February. So hopefully we'll see it published there. But the important thing is that the top 3 causes, ischemic heart disease, stroke, and heart failure, are not the only ones. We have a smattering of other, primarily valvular heart disease and arrhythmia issues. But when we look, we do actually have now a unique identifier for SCAD, which we didn't have before. And SCAD, when we look at how much representation it is within the ischemic heart disease syndromes, because it is an ischemic heart disease syndrome, we see just what we have found in the larger databases that have been recently published. My colleague Sharon just published a scientific statement, which I'm sure she's going to review later in American Heart Association Circulation Journal. And we can see that as women are younger, they're far more likely to have SCAD. And a third of the cardiac issues in women in the age range 20 to 39 are attributed by SCAD. This is a huge, huge amount. Now, these are kind of these were napkin type measurement or calculations that we did last night after we had submitted this overarching type paper. But this follows through what we know. And it seems that about 4% of ischemic heart disease in women is accounted for overall by SCAD. So it certainly is a significant problem. And what we looked at too was by province and region. And we found that women in Atlantic Canada are more likely to have ischemic heart disease, and those that are in Quebec are more likely to have heart failure and arrhythmia issues, and those here in your province of British Columbia are more likely to seem to have valvular issues and atrial fibrillation. So it's kind of proportional Not that they're not more likely, but they're more likely there's an excess per the population of women representation across the whole representation in Canada. So it's not even, is the point. There may be some regional differences, and we need to look into this further. We have also looked at mortality trends for women in Canada. And indeed, from 2000 to 2016, you can see that women are in red here, and there has actually not been a further decline since about 2012, and a slight uptick in the number of deaths that Canadian women are experiencing. And you can see that they always have exceeded proportionally the number of deaths that males have from cardiovascular disease, as I told you earlier. And this is a similar situation in the United States. This is tracking from about the year, 1979, but it seems that in 2000 there was a turnaround in this curve where women were higher in their mortality, which was increasing compared to men. And then the downward shift in the curve occurred up until it crossed finally in the early 2010s, but there has been an uptick. And this is very concerning. And what is even more concerning is that uptick is attributed by women that are younger. Midlife women are those that seem to be accounting for more of the cardiovascular deaths, and that's very worrisome. This was looked at specifically in the Canadian population, in the BC population, by Dr. Humphreys and her team, Dr. VanSCAD2019, and they found similarly that the 30-day mortality of women after an acute myocardial infarction was greater than in men, although it trended down over this time period that they looked for a decade. But what they looked at when they looked was their age and sex interaction. They found that more women were likely to die of cardiovascular diseases within the first 30 days of a diagnosis than men were. Why? You know, that's the problem. We don't know the answer. And certainly, there has been this approach to cardiovascular disease in women as what's called the bikini health. Annette Wenger, she's the doyen of our whole movement in awareness of cardiovascular disease in women. And she said very clearly that, we've just been forgetting that women have things other than our gynecologic organs. And that's reflected in that 2/3 of the research that has been done in cardiovascular diseases has been focused on men and neglected women. How do we move beyond the bikini and protecting women's heart? Well, we have to understand, and this was an effort by the Heart and Stroke Foundation, who put out an excellent report last spring that addressed the 5 unders, and they're not underwear, but it's not Victoria's Secret, but heart disease in women, I thought this was very sad, is under-aware, under-diagnosed, under-treated, under-supported, and under-researched. And to be able to get ahead of that, we need to spend some money and be able to look and support funding and research into why this is. And some of our Canadian journals, the Canadian Journal of Cardiology, has made a special issue actually to address cardiovascular disease in women, and movements like this would happen. So in the last 5 minutes, as it's quickly counting down during my time, I want to just think about why is this happening, okay? We need more research, we don't have the answers. But we have some ideas, right? We have to have ideas. Social and gender factors. There is clearly, and it's been demonstrated, gender bias in cardiovascular care for women. And this is around the world, and certainly in North America, both in the US and in Canada. Social determinants of health. Women that are in less fortunate circumstances are more likely to have cardiovascular disease and be less aware. And particularly for us in Canada, that impacts our Indigenous population and our women of color. And communication. Women communicate differently than men do in many ways. And sometimes it's hard for us to get our stories across and be listened to in a serious way by the healthcare providers that are seeing us when we have symptoms. Risk factors, and I'm not going to go into this because it's just a whole talk on its own, but women have sex-specific, or females have sex-specific cardiovascular risk factors, primarily related to our transition across the lifetime of our hormonal and reproductive status. And certainly we know about pregnancy and hypertensive pregnancy disorders, preeclampsia, gestational diabetes, and how that can impact and increase a woman's risk for cardiovascular disease. Similarly, post-menopause increases your risk for cardiovascular disease. But what I'm going to focus on in the last few minutes is ischemic heart disease pathophysiology and how that can differ in women compared to men. It's true that the most common cause of a STEMI, which is an ST elevation myocardial infarction, is in both sexes is actually a blockage in the heart artery and a rupture of the covering of that membrane over the blockage. And there was a very elegant study that was done a number of years ago and showed that indeed there was no difference in the types of blockages and ruptures that occurred when they studied men versus women. But what's also been found is that women have less severe blockages and they have a thing we call erosion. So that the blockages that occur in the linings are not as stable as those in men. And what was found for many, many years, as you can see these studies go back through 1999, is that women in pink here are more likely to have normal coronary arteries when they go for that dye test for the coronary angiogram than are men. And that's in the setting of a what we call a STEMI or a non-STEMI, which is where the electrocardiographic changes are not diagnostic, or unstable angina. So we are left with this situation of a large number of women that come in with heart attacks, that go for the dye test, and then they're told, oh, it's okay, dear, your arteries are normal. So why do you have a heart attack then? It's quite confusing, right? So this is the situation that a woman is often left in. And that's because women can have different types. Even the standard blockage type can be different because there's erosion. A transient obstruction can occur and then it can clear and it's not present, or is present to be seen on the dye test when the patient goes to the angiogram laboratory. SCAD. SCAD and the awareness of that is huge. You're going to hear all about that, so I'm not going to elaborate more, but that is clearly one of the significant contributors. And there are two others I want to briefly touch on. Stress cardiomyopathy. You might have heard of the broken heart syndrome. Common, much more common in women, particularly postmenopausal women. 90% of the patients are women. And then something we call MI with non-obstructive coronary arteries, or MINOCA is the acronym that goes with that. And that can be due to spasm of the artery, it can be due to abnormal circulation in the small vessels, which doesn't show up on the dye test, the coronary angiogram, and it could also be due to clotting disorders, which are more common in women. Similarly, but less often, there could be inflammatory diseases of heart muscle myocarditis. So I'm not going to go over the SCAD because you're going to hear so much about that in this conference, but that is one of the unique pathophysiologies that occurs in women that may explain some of this difference that we are unable to detect because a lot of doctors have not actually recognized what SCAD was in the past. And a huge amount of work has been done by Dr. Saab to bring attention towards that, to classifying the types of abnormalities to be looking for on an angiogram. You'll hear a lot more about that. Very recently, the fourth universal definition of myocardial infarction has included Takasubos and MINOCA. And they have focused specifically on explaining more about Takasubo, which actually was something that was initially described at Mayo many years ago, almost a decade and a half ago now. And now there's a huge international registry, which I would give you these references to go to, which has summarized very nicely and proven that the majority of the cases are women, as you see in the light blue bars, compared to men, and that the age range is higher as opposed to the age range for SCAD. And the Takasubo occurs in the setting of significant triggers similar to SCAD, which can occur with triggers physical, emotional, but a third of patients have really no identifiable triggers, which can make it more challenging. We used to think it was a pretty benign thing, broken heart syndrome, and it was going to get better because that's usually what happens with the course. It's thought to be an excessive catecholamine outpouring, which stuns the myocardium, and then it gradually recovers. But we know that there can be significant complications in at least 10% of patients. Shock, cardiogenic shock and death is certainly present. So it's not so benign. And when studies in that registry have looked, we see that the incidence of having a major adverse cardiac event in the next decade is very significant, at least 40% of patients. So the MINOCA, just shift into that, as I mentioned, when there's no significant epicardial coronary obstruction, it seems to occur more commonly in women. This was a large study in Virgo. Up to 5 times more women are more likely. It was a matched study of men and women with acute MIs less than 55. And 5 times more women than men ended up with MINOCA. They went to the cath lab, there was no significant blockage. This, as I mentioned, can be caused by one of the major things we have to watch for is a lack of recognition of SCAD. And so that is something that we have encouraged physicians to go carefully and look at the angiograms again and get a second opinion and make sure it's not, in this case of SCAD, is actually the cause of NOCA. But other causes would be a plaque rupture, plaque erosion, a thrombus which has resolved, or with the other things I didn't mention, but vasospasm and then the small vessel disease would be other causes. There is a great reference which just came out in another scientific statement. So we're getting these scientific statements which are now focusing on the unique pathophysiologic aspects which are represented more often in the female population. This is a very good, it was in circulation, very good reference in April 2009, which gives kind of a traffic light approach. So it means like stop if it's, we have an MI, but there's no obvious coronary angiogram, but there's a medical problem of sepsis or pulmonary embolism, then it's probably not anything to worry about other than the main problem. A working diagnosis, the issue is SCAD appears prominently, as well as differential as Takasugo. So physicians must be aware of this now, and we have an approach to it at this point. You can refer to this article for all the details. So in summary, heart disease in women is real, and it's real in Canada. It's real in the United States, it's real all over the world. But we have a major problem, and the issue is that we have more to think about in women. Unfortunately, our paradigms that we have learned in medical school, where we have obstructive coronary artery disease, which is the most common way that coronary artery disease does present in men, you know, women just have a lot more buttons here going on, and it's a lot more complicated. There are a lot more factors. So I think to underscore an understanding of sex-specific aspects of cardiovascular disease is absolutely essential to provide optimal treatment and improve the outcomes for women that have cardiovascular disease. And it's true, women are different from men. They're just not equal to small men. And I thank you for your attention. I'm happy to answer questions.
Thank you very much, Sharon. May you have a seat? Great.
All set.